Hi, this is Dr. David Lewis with McLaren St. Luke's Brain and Spine. If you're watching this video or any of these videos, you've probably seen me in the office, and this is going to be a little bit of a refresher about what we talked about for your particular operation. So these are some images that come from a patient who needed to have a kyphoplasty, which is a procedure where we inject cement into a bone, mostly with a compression fracture. These top two images are MRI images of the lumbar spine, and what they show us is that this bone right here, which is L2, is fractured. On this particular image, what we see is that the body is not shaped the same as the other vertebral bodies. It looks like it's smushed in the middle. It's not as tall, and the top and bottom aren't parallel like they are above. And so that's what a compression fracture looks like. This other image to the right is called a stir MRI image. And what this shows us is that there's edema in that bone, which is an indication that it's an acute or relatively recent fracture. And we like to see that before we would talk about doing the kyphoplasty procedure to be sure that we're not treating a fracture that's old and healed a long time ago. And then these lower two pictures are x-rays taken in the operating room after the kyphoplasty. So this is that same vertebra, L2. This is the same kind of view as the MRIs, it's just rotated 90 degrees. So the patient's back is at the top of the screen instead of on the side. And the dark stuff here is the cement. The cement itself isn't really dark, but we put contrast in it so we can see it. And you can see how we fill the vertebral body as much as we can to provide support to keep that fractured bone from moving around and help alleviate the pain. And then here is a straight on picture of that vertebra where again you can see the cement filling into that bone. So you can see it fills most of the width of the bone and the height of the bone. And then on the other image, we can see that mostly we're toward the front of the bone. We tend to not try to fill the very back because we don't want to risk pushing anything into the space where the nerves are. So this is a reasonably good result of cement in a kyphoplasty and a good example of what a compression fracture looks like on an MRI. So I'd like to just talk a little bit about the kyphoplasty procedure. Chances are you've seen me in the office and we talked about doing this operation for you, and that's why you're here. So hopefully this will be a refresher. Kyphoplasty is a procedure where we inject cement into a bone that has had a compression fracture. And it's really pretty straightforward. It's generally a very quick procedure. Usually it takes longer to get you to sleep and in position and the x-rays lined up than it does to do the surgery. We would almost always plan for you to go home the same day as the procedure. And it's typically done for compression fractures that mostly are associated with osteoporosis. It's really simple how we do it. We use x-rays to provide guidance, and we make two small incisions on either side of the spine and pass a small needle down into the bone. And through that needle, we pass a balloon that we use to create a cavity within the bone that's fractured. And then we inject cement into that cavity to stabilize the bone and help minimize pain. For many people, this surgery is very effective. Often people notice a significant improvement in their back pain as soon as they wake up from surgery. However, there are risks with the procedure, just like with any surgery. And one of those risks is that it may not help you feel better. Unfortunately, it's just not possible to accurately predict in every case who's going to do well from an operation. I certainly wouldn't take you to surgery if I knew you weren't going to get better from the procedure. Thankfully, though, most people do get significant improvement. In this case, the incisions are very small, but there are still incisions, and so we worry about bleeding and infection. The risk of significant bleeding is minimal in this surgery. I still ask permission to give a blood transfusion just in case, but it would be exceedingly unlikely to need to do that. It's also very rare to see infection with this procedure, much less than a 1% chance. The incisions are very small, they're open for a very brief period of time, and they typically heal very well. Other things that can happen, but again are very uncommon, are that it's possible that one of those needles might travel somewhere that you don't want it to while we're placing it into the bone. My job is to not do that, and that's very rare to do with the x-ray guidance that we use. Another risk is that the cement can leach out of the fractured bone. Sometimes there are clefts in the bone and the cement gets into the disc space or things like that. And that may not cause any difficulty at all, but in some cases it might actually lead to a compression fracture at the level around where we're doing the surgery if we have hard cement pushing up against soft bone without the disc in between. So occasionally we'll find that a patient will suffer a new fracture, and if that happens, we can do a kyphoplasty for that as well. A lot of times patients who develop these fractures are at risk for developing more, and so even if there are no difficulties with the injection of a cement, we can still see patients develop several compression fractures over time, and we can continue to do the kyphoplasty procedure if it's been helpful. As I said, it's a pretty quick procedure. Unless you have very severe medical problems, we would expect you to go home the same day. And the cement that we inject sets very quickly and is really as hard as it's going to get by the time you get to the recovery room. As a result, there aren't really any specific restrictions after surgery, although in general, if you're having these fractures, it's probably not a great idea to be doing a lot of heavy lifting or really strenuous work with your back. But in terms of restricting your getting around or things like that, there's no restriction after surgery. As is my usual routine, I still plan to see you 2 weeks after surgery and generally a month after that. And for most people at that point, they're doing well and we don't feel that further visits are necessary. But if you are having any problems or concerns, we can always schedule additional appointments as needed. For most kyphoplasty procedures, it's nothing more than that. For some patients, their fractures might be due to the presence of tumor in the spine as opposed to just osteoporosis like I discussed previously. In that case, we still do the same kyphoplasty procedure, but we can also do a procedure called an osteocool ablation, where we place probes into the bone that heat up the bone to try to stop the growth of the tumor prior to placing the cement. And that can be pretty effective at helping treat pain associated with tumors in the bone. And there is pretty reasonable evidence that it helps slow the growth of that tumor as well. So those are the two main reasons we do that procedure. Like I said, it's usually quick, usually out of the hospital same day, and for many people, a very quick improvement in their pain associated with their fracture. So I hope you found that helpful. Again, if you saw me in the office, that's hopefully pretty familiar. And if you're just happen to be watching online and you'd like to have a consultation, please feel free to reach out to McLaren St. Luke's Brain and Spine, and we'd be happy to schedule one for you.